We'd like to welcome you to this, what we believe is a really important and critical session on universal health coverage. And we can see that many of you are interested in this. Many of us believe that universal health coverage is a core of the Sustainable Development Goals, is one of those goals that really also defines so much else that we want to achieve with the SDGs. The Director General of the World Health Organization often says it's truly at the core of the SDGs. It's about people's health and well-being, and of course it covers a wide range of health services, but also prevention, health promotion, palliative care. We've been at a really critical historical moment, and this is what I hope we'll also be able to discuss, is that at the United Nations, at this year's UN General Assembly, a high-level political declaration on universal health coverage was adopted, and that is the background of our discussion here today with this really distinguished panel. I'll just give you a short rundown of who is here with us, and then the way we'll proceed is we've agreed on a set of questions where we'll do some rounds with this panel rather than have 3 consecutive keynotes. We've sort of broken them up a little bit, and that I hope will also be of interest to you. So first of all, we have with us Dr. Carissa Etienne. She is the director of the Pan American Health Organization. Welcome, Carissa. We have with us Dr. Gitinji Gitahi, who is the Global CEO and Director General of AMREF Health Africa Group, and I'm happy to say, together with me, the co-chair of UHC 2030, and you'll hear more about that. I have to my left, Dr. Harald Nusser, who is with Novartis here in Germany, the head of Novartis Social Business. To my right, we have Dr. Fredrik Christensen from the Coalition for Epidemic Preparedness Innovations. Many of you will know it as CEPI, and he's the deputy CEO there. And then we have a special guest of honor here, and we're incredibly happy and proud that she is with us, Dr. Margaret Chan, the former director of the World Health Organization. And then we have Dr. Dennis Snower, who is the head of the Global Solutions Summit that focuses on the Sustainable Development Goals and how we can best achieve them. So we have people who are really deeply involved with universal health coverage. We are people who are involved with other sectors and with political action who see universal health coverage as important. We have colleagues from the private sector who are contributing. We consciously wanted to see where is this interface between universal health coverage and health security, because again, Dr. Tedros says it's 2 sides of the same coin. We don't want to juxtapose them. We have the opportunity of a longer historical perspective also from Dr. Chan. This move towards universal health coverage did start also under her leadership at the World Health Organization. And and we have special aspects that Dr. Gitinji, GG as I call him, will bring, particularly related to the community health dimension, and I hope also the women's health dimension that we've spoken about so much. So Carissa, I'd like to ask you first, could you give the audience here a very short rundown of what was achieved in New York from the perspective of WHO, from the perspective of the Pan American Health Organization? Was this really this historical breakthrough that many people speak about?
Thank you, Ilona, and good morning. It was monumental. Many of you are probably too young to know this, But in 2009, I was Assistant Director General for Health Systems and Services. Dr. Chan was DG. We had to fight to say that you need strong health systems to achieve many of the vertical disease programs that were underway. It was a fight. We had primary health care as one of our priorities. Nobody, very few people were ready to listen to primary health care. We had to stop using the term primary health care. And then we went on, under Dr. Chan's leadership, to develop the World Health Report 2010 on universal health coverage. And then gradually it began to gain momentum. Gradually we were then able to reintroduce the whole concept of primary health care. PHC as a term had disappeared from the WHO literature. So yes, this was monumental, historic. I think it places health at the very center of the Sustainable Development Agenda. It elevates universal health coverage to the highest political level. And that is also very important. It was a global call to action. And it reaffirmed that health is a human right. It means universal, and universal means universal. It speaks to all people having those rights, all peoples having access to health services and coverage, but also to the social determinants of health. I think it raised also the fundamental importance of equity, social justice, and solidarity, and social protection. So that too was extremely important to reaffirm this. And it spoke about the elimination of stigma and discrimination. The whole need to focus on the poor and the people who live in conditions of vulnerability as one of the priorities. Very important for me and very important for the world, very important for the achievement of universal health is the fact that primary health care was cited as the main approach to transform and to strengthen health systems. And it clearly stated that health is a responsibility of the state. It is a political choice. And for that, we need strong, transparent governance and stewardship. A stewardship that allows full participation of all of the citizenry. A governance that is a whole of society approach, but also engages civil society, engages the private sector, but allows for the voices of so many who have not been hitherto heard. It calls for the participation and the development of mechanisms to ensure that full participation. And I think it gave us a clear path for action. Certainly the whole question of meaningful participation, the implementation of high-impact policies to protect people's health, and addressing the social, economic, environmental determinants of health through a multi-sectoral approach. Some of you will remember that we began speaking of the multi-sectoral approach as early as 1978. Yes, I was alive and I was a health professional then. And for many years, we've had great difficulty in implementing a true multi-sectoral approach, and it reemphasizes this as one of the clear paths for action. And we need to work to prioritize health promotion and prevention. I think that too came out very strongly, and to strengthen the first level of care, including technology and the access to technology and human resources as well. It also, and that part I didn't agree with, it also called for increasing public expenditure in health by 1% of GDP. I'm afraid that's not going to get us to universal health. I beg to differ. And I think also importantly, the need to strengthen national health authorities and national health leadership, and to include the essential public health functions. I think in summary, those were some of the important areas for me.
Thank you very much. And I'd like to draw your attention to this publication. There are copies outside, Health, a Political Choice, where you get many of the statements also from heads of state and government on the importance of universal health coverage, and from many of the actors that Carissa referred to. Of course, there were some elements that not all of us were very happy and that were missing. I refer to sexual and reproductive health and rights. And some of you might know that there was a long, very, very difficult political negotiation, and there was fear at one stage that because of this agenda and because of the migration agenda, the high-level political declaration might actually fail. One must say that the co-facilitators of the process did an extraordinary job to actually finally get a consensus, to get a version of the high-level political declaration that still fulfilled the historic elements that Carissa said, and but that allowed a discussion in the high-level meeting about the differences that do exist in relation to that issue. I'd like to turn to Gitinji, particularly in terms of your role as the co-chair of UHC 2030. UHC 2030 is exactly the kind of platform of the many actors, as Carissa said. And in order to help move the discussions for the high-level meeting forward, UHC 2030 developed 6 asks. And maybe, Gitinji, you can reflect on those 6 asks, on ask number 7 that came afterwards, but also what of the asks was reflected in the high-level declaration, and where do you think work still needs to be done? Carissa already said, you know, that 1% is perhaps not enough, and I think there are some other elements that you might want to highlight.
Thank you. Thank you, Ilona. I think first is to celebrate that we ended up with a declaration. And I would like to ask everyone here to stand and clap to ourselves that we actually achieved a declaration. Let's celebrate the small gains in global health. We achieved a declaration, and that was really major, because as Ilona has highlighted, a few weeks before, we were talking to each other and wondering, are we going to have a declaration or not? And we were really worried. We started working on a plan B. But you see, yeah, you're watching us. Yes. So at least we did not have to effect the plan B. We actually had a declaration. That declaration, at some point, Ilona told me, this is a Christmas tree. You know, we have, you know, many things in between, 83 paragraphs. But at the end of the day, we had the declaration. And many of the things that we wanted captured were actually captured. So that was, you know, that's something we must celebrate, because even as we say there are things that we didn't achieve, this is a journey. It was the first time that we're having a high-level political declaration on universal health coverage ever. Now, the multi-stakeholder platform that is UHC 2030, which is made up of civil society, private sector, academia, governments, had been working behind the scenes for 3 or 4 months before the high-level meeting, and the work was largely around collecting views of different stakeholders to feed into the process, to assist the co-facilitators, Thailand and Georgia, and the President of the General Assembly, to develop the declaration that was then going to be negotiated by members. So in the process, we did come up with what we're calling the 6 asks, plus what was pushed for by the, you know, by the women, the gender equality, women in global health, on the 7th ask, which we thought in the movement that should be more of a cross-cutting issue, because we felt that the issue of women and girls' rights and gender equality was actually the center of gravity of universal health coverage. So we didn't see that as a separate ask. It was actually going to be the ask across all the other issues. And we had 6 of those, and the first one was going to be political leadership beyond health, looking at UHC as a social contract between governments and their people. That was the first ask. The second ask was around that no one should be left behind. And therefore, the debates that were there around migrants was actually quite painful for us to see, that actually we felt that some parts of the global citizenry should actually be left behind. So the leaving no one behind was the second ask of the movement. The third ask of the movement was that because of the complexity of the health system, especially the debate which has been with us for a very long time around private sector this, public sector that, and all these things, and the centrality of equity in UHC, we felt that government needed to legislate and regulate so that there's a framework within which everyone operates towards equity for universal health coverage. Then we said that quality needs to be at the center. So upholding quality of care was important. And we noted that quality in this case was not necessarily excellence. It was optimal quality for the best outcome based on where the individuals were. And then we talked around the issue of investing more and investing better. That actually investing in health for UHC was not purely about just about more money. It was also about how the money was spent. And we'll talk about this when we come to talking about achievement of UHC in low middle income countries. And then we looked at finally moving together. Moving together, looking at all sectors together, not one. Government, non-state actors, everyone together to achieve UHC. When you look at the declaration, actually, a lot of these issues were actually reflected, because beyond those six asks, we then developed targets as well that should be achieved by 2023. And if you look across, I was counting the paragraphs, actually, and I think about 37 paragraphs reflected the six asks and their targets as well. So it was a major, major achievement. So maybe just to mention one or two. Number one is that we did achieve to get the commitment for another high-level meeting for UHC, which is 2023, which also kind of coincides with the targets that we had put within the six asks. The other thing is that we have the commitment to have reports at the 75th and 76th General Assembly on this declaration. I think Carissa talked about the financing. Many of the civil society organizations prior to the declaration were pushing for 5% of GDP. Many countries that are struggling at 2-3%. So WHO and the declaration ended up with 1% additional. So we also, I agree with you that actually we need more to move more towards the 5%. I think 1% is not enough. But we also agreed that we are going to add 1 billion more people onto coverage by 2023, which is also within the six asks. So there was major progress, and there were many things that were mentioned, and also the recognition of the UHC 2030 platform within the declaration was a major win, because it means that multi-stakeholder engagement is a recognized approach to some of these global declarations, yes.
Thank you very much, Gitinji. That I think is very helpful, and I'd encourage everyone to go on the UHC 2030 website and look carefully at those six asks. We see our role as continuing to promote them. And for me personally, one of the most important statements is in the six asks is that health is a social contract. And that really it is an expression of solidarity within society. Societies organize that solidarity in different ways, but definitely, and we see that in many of the social movements and even uprisings over the last years in many parts of the world, that the lack of such a social contract for health is actually leading to political instability. And therefore, that role of having a society that is willing to support its weakest and most vulnerable members is very important. When UHC is discussed, of course, public finance plays a very important role. The fiscal space plays a very important role. But as we know, as a platform from UHC 2030, the private sector also plays an important role. And in some countries, such as India, the major part of primary care and healthcare is actually provided through the private sector. Many countries with social contracts have private providers within the context of the social contract. So I'd like to ask Dr. Nusa, what your view from the private sector perspective has been on this declaration, on this achievement. How have you contributed? We had close collaboration with the WEF, for example. So from the view of your company and, let's say, the private sector in a larger view, how do you see this movement for UHC?
Thank you, Ilona, and thank you for mentioning India. I will come to India in a short moment. When the question comes, what is the role of the private sector, I usually wonder, I wonder whether there is the role. The private sector, I guess, needs to define individually a role. There is no such thing as the perfect health system. There is no such thing as the private sector's role. Each individual needs to define what it can do best. What that means for my company is that it is important to address societal matters with business models, so that making business is not necessarily non-combinable with doing social good and environmentally good as well. So what Novartis has done 11 years ago in India is to start a community program called Healthy Families, where societal work like education on health, on sanitation and hygiene was independently combined with the usual commercial approach promoting essential medicines adjacent to those communities. This model has proven to be around for 11 years now. It is financially sustainable, so it's adding to the core what a pharmaceutical company usually wants to do, and it is generating societal returns and contributing to not only universal disease control, but indeed universal health coverage. And this is something which is important on our journey, the social business journey that my team is representing within Novartis, to also reflect on the narrative, reflect and be more self-aware of our role as a private sector organization, which indeed needs to focus on health rather than on diseases, which needs to look at the patient at its core. That's easy said, I know. But what I mean with that is that at the community level, there usually is not a tertiary care hospital, right? So decentralization of care and promoting this with business models is important, because people present with a fever. They don't present knowing that they have malaria. They present with a fever and may also have hypertension and gestational diabetes at the same time. So strengthening primary health care as a key pillar of universal health coverage is what we try to build business models around, and have successfully done so in India and also in Vietnam, and increasingly also in Africa. And with that, many disease areas can be addressed, and with that also a health security topic can be addressed, not only to prevent developed countries from spreading diseases or hemorrhagic fevers, but also by strengthening the community. The community is getting less vulnerable to undue influence from people who don't mean good, who just want to make sure that they can get further followers, like terrorist organizations, for example. So we are increasingly aware of the role we can play, and we have to play, and link this and bridge that. And I guess we come to that in the sequel of the discussion, how the usual traditional thinking of a private sector organization developing individual medicines for individual diseases can be nicely combined with a more community-based approach.
Thank you very much. And of course, I'm very happy about your comment. We had a big discussion of that also in UHC 2030. There is no such thing as the private sector. It's becoming more and more diverse in relation to health. New types of companies are entering the health sphere, particularly in relation to digital health, etc. So one needs to have a much wider view. I'm going to just stop for half a minute to allow all those people standing there to find a seat. So let's have a bit of unrest, and please help your colleagues by moving a bit and letting them come in. There's lots of seats front here. Okay. That's better. Now everyone can sit comfortably. I'd like to turn to Dr. Christensen. You, of course, are involved in a whole number of ways with epidemic preparedness, and Dr. Nussel already sort of alluded to that. And I'd like to come back to this point. You know, how do we bring two agendas that are usually seen as very, very separate together? How is that from your personal view, from the CEPI view? How can the kind of work on emergency preparedness be a basis for UHC and the other way around in a way? What's that dynamics?
Yeah, thank you, Ilona, and thank you for inviting us to this panel. I think I'd like to pick up on 2 points that have been made already, which sort of support my view that these two agendas really do feed off each other and support each other. Of course, they are slightly different, but at the same time, there are particularly 2 points that I'd like to make in terms of them being, have to be based on fundamentally the same thing. And one is the primary healthcare point of view, that also health security has to start locally. And that's close to my heart as an earlier general practitioner. I think having a well-functioning healthcare system begins with a primary healthcare system, and you have to build on that functioning day-to-day healthcare system, both for universal health coverage as well as for being able to address major health security issues. So you can't really have universal health coverage without also having health security and the other way around. I think the other main point is that both agendas really build on a whole of government, whole of society approach. You need to engage very widely, everything from country leadership, but also then, and maybe particularly for health security, having good coordination and alignment between both the local, national, regional, and global partners. Last month, the Global Preparedness Monitoring Board report came out, and from a CEPI point of view, we were of course happy that they focused on the threat of a major pandemic. So if there's a new highly lethal airborne pathogen that starts spreading either from natural causes or non-natural causes, we've heard these numbers, but it's really mind-boggling that it could kill 80 million people in a matter of months and really wipe out 5% of the economy. And so they pointed to the fact that we are making good progress in trying to prepare for this, but there is still a lot to be done. And the world is not really prepared for that kind of scenario. And of course, if there is a scenario like that, that would really hit universal health coverage and the ability to have a well-functioning health system at the same time. They pointed to a number of recommendations, and I'd just like to highlight 2 of them. One was the invite for other international funding mechanisms to expand their scope and also include health emergency preparedness. So they called on both the Global Fund for AIDS, tuberculosis, malaria, and for Gavi to take these considerations into account. Because I think if you have a good local and regional system, they still need to be supplemented with global preparedness as well. And they also pointed to the fact that we need to develop frameworks for non-influenza infectious diseases, how to share sample and information sharing for those kinds of diseases as well, and give countries trust that if they do share samples and data, they will get access to those results as a consequence. The other recommendation was to ensure adequate investment in developing vaccines, therapeutics, and surge manufacturing capacity. Again, fundamental for health security, of course, but also very important for universal health coverage. And in all of this, CEPI is just a small but important part of the bigger system of being well prepared. But I'm glad that we've been able to get established and get some progress and being pointed to in this report, as well as I saw the report from the G20 Health Ministers Declaration that also support, we're very encouraged by the developments from Gavi, from WHO, and other partners.
Thank you very much, and thank you also for drawing attention to the fact that not only did we have the declaration from the high-level meeting at the UN General Assembly, but there was a good sort of alignment of the stars in that year that both the G7 and the G20 took up issues that were highly relevant, and particularly the G20 with a strong focus on universal health coverage, and the G7 with a very strong focus also on women's issues and equity issues. So again, one must say that particularly Japan, who hosted the G20 this year, and if any Japanese colleagues are here, a very, very big thank you. Japan organized, I would say, a very concerted strategy to have UHC on many high-level political agendas, and also creating in New York a group of friends of UHC that brought representatives from the different countries together, that brought UHC not only to the health ministers meeting, but also organized in the context of the G20 the very first joint meeting of health and finance ministers, particularly because of the challenge of financing UHC. And also then, aside from the health ministers meeting that was just last week, and we'd recommend that resolution as well, but brought the UHC agenda to the deliberations of the heads of state. So I think one can also see in terms of health diplomacy what a difference a concerted political strategy, a health diplomacy strategy can make. And we'll have more discussions on that also tomorrow at one of the closing panels. I'd like to turn to Margaret Chan and say, Margaret, when you hear all this, much of that movement started under your leadership. And Dr. Tedros has frequently said how the kind of things he is doing, he is able to build on what you have started. How do you feel when you hear this? And what are things that you said, I'm glad we're there, but we need to continue to push that? And share your thoughts with us.
Thank you. First, Ilona, thank you very much. I'd like to thank the World Health Summit for the invitation. And it's good to be back and see so many old friends and new friends. You asked a rather loaded question. I'd like to make 3 points. For those of you, well, it's no secret that I retired from WHO in 2017, right? 2 years down the road. What have I been doing? Nothing. I kept my promise.
Not true.
I kept my promise to my family that I will do nothing for 6 months, only for 6 months. And then I started gradually to think about life after retirement. What does that mean? I've been away from my family for 14 years, living in Geneva alone. So I owe it to my family. So family comes first. Now, for those of you who are near retirement, already in retirement, you may disagree with me, but that is a wonderful feeling, family. Now, but 2019 is a very important year for me, and this is the year that I begin gradually to ease into global health again. I attended 3 important meetings in 2019. There is one in January, February in Thailand, Bangkok, PMAC. And then the one that I was asked to organize by the current chair of the Boao Forum, who is no stranger to all of you, Mr. Ban Ki-moon. He's a chair of Boao Global Health, Boao Forum for Asia. And you know how passionate he is about SDG. And he said to me, he said, Margaret, I don't think I can get rid of you. Neither can you get rid of me. We need to work together. So because, you know, the SDG 2030 is such a huge agenda. And among the 17 goals, well, dare I say, that's a bit of my view. Goal number 3 is most important. And 3.8 is most important. Well, you may say I'm arrogant, but that's our experience. So, I mean, now I'm attending the World Health Summit. So all these 3 very important global health forums that I begin to use them to ease in, because I need to live up to the promises I make to all the member states of WHO. When they gave me the honor of DG Emeritus, I raised one question with all my member states. I said, do you mean I need to continue to work in global health but without pay? And they all agree, so here I am keeping my promises. Now, the second point I also would like to raise is I agree with everything that Carissa said. It was a fight. But when it is a tough job, give it to a woman, and she will do well. It has been amazing. I mean, the momentum, the achievement of this movement of UHC. I was a bit upset when I heard, you know, Carissa said the term primary health care disappear from WHO agenda. And she was correct. Why? And this is one thing I learned from WHO. And having been in global health for 40 years, yes, I look young, but I'm not. I'm 72. So anyways, fashion, it's just like women. It's the same thing applies to health. In the old days, we call it health for all, based on primary health care. And people got so misunderstood about primary health care, and there was other problems as well. The fight between the clinical people and the public health people, and some people say that it is absolutely, hopelessly utopian. And for those of you who remember our respected Dr. Mala, he was instrumental in promoting the concept of health for all. I had the privilege to work with him during my tenure. And I asked him one question, which I would like to share with colleagues here. What went wrong with health for all? Because she's so good. It's all about justice. It's all about addressing inequity. He said, Margaret, because we don't give people the means to deliver it. So Carissa, at that time, a very brilliant woman. So that's why you're now the regional director of PAHO. That's a promotion, isn't it? So anyways, I said, Carissa, take it forward. And let's implement health for all through primary health care. But now we call it UHC because politicians are very forgetful. They like, just like women, they like fashion. So now the fashion is, we call it UHC. And all the stars were aligned. We get the world's guru, and Ilona Cakebush was one of them. And we just put this movement forward, right? And I have to say, for a retired person, this is really music to my ears. Now, the last point I'd like to make, why global consensus is so important The UN General Assembly in 2015, leaders of the world adopted SDG 2030, leaving no one behind. And for China, in this case, I like to make a reference to China. The president of China, President Xi Jinping, actually he attended this meeting. He strongly support multilateralism, and he strongly support global governance. And he kept his promises. So he went home. The poor Minister of Health has to develop something they call Healthy China 2030, exactly to keep his promises, because he is one of the leaders, the world leaders, that adopted the 2030 agenda. So there's no two ways about it. So now universal health coverage is a big thing in China. About 95% of 1.4 billion people were covered. Of course, you may say that is very basic. Is primary health care? Yes. When you have the means, I advise the Chinese government, you just move up the ladder. Because no country, no matter how wealthy you are, can do it in one step. So, ladies and gentlemen, support multilateralism, support women, and support global consensus. It's important for humanity of this world. Thank you.
Thank you. Thank you, Margaret. I think it's always important to have also these political perspectives and to see how political will is created, how it wanes, how it comes back. And I think particularly global health is very subject to a lot of fashions, as you call them. And it's good that we are sort of coming back to the core. And of course, also last year was the meeting in Astana, which followed up on the Alma Ata Declaration on Primary Health Care and also contributed to this rediscovery, this recommitment. We're very lucky to have here with us Dr. Snower, who is the president of the Global Solutions Initiative, as I said. And that brings together think tanks from all around the world to work on global solutions for the SDGs in particular. Dr. Snow, if you hear all these health people speaking and you relate that to the overall commitment you have made to help implement the Sustainable Development Goals, you hear how the whole intersectorality, the whole of government approach is so central. How do you think health needs to enter into your initiative? How does your initiative need to perhaps consider health more? And where can you be helpful? What's your advice also to all these health people? Should they do something differently, or are they on a good track?
I'm very grateful to be on this panel, and particularly following Margaret Chan, who's made an absolutely essential point, which is that global consensus is absolutely vital to establish UHC. And the Japanese G20, which we supported through the think tanks, has made a very important first step to put it on the global agenda. Now, the next step, I believe, is establishing a powerful narrative that will get us there. Say, why do we not achieve global consensus? And one important answer is we don't have a powerful narrative. I believe that UHC, the establishment of it, is analogous to the abolition of slavery around the world. And slavery did not get abolished through a high-level declaration alone. It was important, but not the only thing. The narrative is really important. Now, what is it that could provide the substance of a narrative? And I will give a shot at it right now. We have diseases of want and we have diseases of plenty. The diseases of want are in the poor countries, and they will not be able to overcome them on their own, and they will need support from the affluent countries. And elimination of these diseases of want is possible technically by sharing information, generating necessary skills, redistributing a small amount of income, but it's not done. And it's not done because the people in affluent countries and their governments don't want to do it, otherwise it would have been done. So the right question to ask is not how do we do it, but how do we get the people in the affluent countries to want it? And that is what the narrative does. And then there are diseases of plenty, like obesity, tobacco-related disease, depression, burnout, diabetes, various cancers, etc., etc. We have the ability to eliminate them too, and don't do so. And the question there is, to my mind, another wrong question is asked, and that was in a question that you addressed, that is, medicine deals primarily with treatment and not with prevention. And we should look at health rather than disease. And in order to, and I believe that these two wrong questions and the two answers are related to one another. And I suggest, in order to focus ideas, fix the mind, suppose we compare, as has been done before, healthcare with aviation security. Okay. Modern medicine, people can live unhealthy lives, that's their democratic right. But if they fall ill, then it is the job of the state to cure them. And the question is that the best way to think about it? Now, with regard to airline safety, the equivalent of that would be we allow pilots to fly without license, we eliminate security checks, but if a plane falls from the sky, then we will be there and rescue these people and get them to the hospital. And as a result, this would be a very expensive operation, right? Because lots of planes would fall from the sky, lots of people to be rescued. Private enterprise could turn this into a good business, but it would be inefficient. So what we have in place currently is an airline safety procedure globally that is virtually entirely devoted to prevention. Servicing aircrafts every few months is mandatory. Information about weather conditions is automatically available to everyone. Pilots and other personnel get formal, rigorous training in airline safety. Many safeguards are in place that are implemented automatically. All major accidents are investigated by a national body, and the reports are published without question, and pilots are usually immune from prosecution. Now, most importantly, the safety of all passengers is considered equally important regardless of what they paid for their plane tickets. If they pay more, then that goes into comfort and luxuries, not into safety. Now, suppose we had this approach to health. Where would this take us? Well, everyone would get mandatory health checks. Information about healthy living would be automatically available. Everyone would receive rigorous training in health maintenance in school, at work, and elsewhere. Rules for protecting health would be rigorously enforced, bottom up. As you said, local level is really important. Health safety checks would be in place automatically at home, workplace, elsewhere. All major outbreaks of diseases would be investigated and reports would be published. Doctors would receive immunity from prosecution, and basic health of all people would be given equal attention regardless of what they paid for health care. And variations in health expenditures would go into comfort and luxuries. That's where we would be. Now, interestingly enough, I claim that this narrative would push us in an important new direction, because It would allow the local level, regional, national levels to work in consonance with one another. It would allow different countries to join forces within the G20 proposals that Japan has made, driving in the same direction. And it would focus us on something else. The most important doctors in this new scheme would be ourselves. Obviously, we'd rely on a lot of health professionals, but to say that this is a social contract, this is not just a social contract that's binding on the government, it's a social contract that is binding on every individual. And to get a narrative in place where every individual feels that they have an obligation to society that then gives rise to obligations from their government, obligations from all other governments abroad, would pull this together and hopefully make it happen. I think in the second round, I just have one other point to make, and that is how precisely we can make it happen.
Thank you for that. So I'm sure the speakers will come back to this proposal. I think there's a lot of interface that you highlighted, which is also what we in the public health world discuss around the determinants of health, so that we see that while it is in many cases difficult for people at this stage, because there is no social contract on health, to actually fulfill their individual obligations. If there is no framework convention on tobacco control implementation, and every time I go through an airport, I'm sort of attacked by the selling of cigarettes and vaping products, and continuously an environment that doesn't help us. So I think your point also, that narrative will need to include that environment, which is so much in terms of determining our health. Carissa, I'd like to come back to you, because in some cases, if we look back, some of the countries in your region were actually leaders in taking us forward around primary health care, universal health coverage. I think particularly Brazil played a very important role in providing access also to AIDS care, etc. Where do you see the situation in your region now, and what are the challenges? We say health is a political choice, and it seems that some countries are not really taking that choice right now. I'm well aware that you will not be speaking about individual countries given your role, but where do you think that political choice is positioned, from the top, from the bottom? How can one move the universal health and primary health care agenda forward politically?
So thanks for this question. I think the history is important. So in the Americas, there is a very strong history of commitment to the right to health. It is enshrined in many constitutions. And in fact, citizens take it, albeit the higher middle class, take it very seriously, because governments have faced legal challenges based on the right to health. So there have been a number of mandates and resolutions that member states themselves have participated in crafting. So in 2006, we had the renewal of primary health care that began the whole movement for health for all again. And over the time, political governments have changed, but they've remained true to the central issue of health as a human right. True, this is under attack by one or so countries, but generally that continues to hold. If we look in 2014, they passed the whole resolution on universal access and universal health coverage and access to social determinants of health. And there too, there was very strong political commitment around this. And we see this year that they have passed the strategic plan with entitled Equity at the Heart of Health. And there they have 28 or so targets and indicators, but many of them rooted in the health system, many of them rooted in access issues, many of them rooted in health as a right, also the increasing of the public expenditure on health. So despite the political changes, there continues to exist in the region a very strong political commitment for access to health. Now, we also have to acknowledge that the Americas is the world's most inequitable region. So this inequity feeds into, from time to time, social strife. And within this context, the recent movements in terms of the crises in many of the countries that we are having now in the Americas really is a pushback on that inequity, that people no longer feel that it is acceptable, that they don't have equitable access to health, to work, to education, and that these masses are pushing back. We have had some sterling examples in our region, Brazil, as you mentioned, with its SUS, Cuba with its own unique system as well, but many other countries. The Global Monitoring Report made this fact very, very clearly, that we have an index in terms of utilization of health services that's the highest in all of the world, in our region. So yes, the commitment continues. For instance, this year, we've had, 2 years ago, we've had a pushback on reproductive health and the right to that. But there is such solidarity among our member states that usually they can arrive at a negotiated decision to move forward. And within that general context, what we see replicated at the national level, it's their regulations, their legislation. In fact, many countries have passed legislation at the national level in support of universal health coverage, in health reforms based on primary health care. So I think it is holding strong, and yes, our region aims to be the first region to arrive at universal access to health and universal health coverage. Thank you.
Thank you, Carissa, and thank you for drawing attention to the global monitoring report that was prepared for the high-level meeting that I would recommend to you if you're interested in more data on this development. Gitinji, can I come back to you and ask you perhaps for a glimpse, like Carissa gave us for her region, in terms of the African countries? You know, where do we see leadership? Both, you know, from heads of state and government, but also where is there strong civil society movements? Where is there a call, a demand also for universal health coverage, for community-based services, etc.? Could you give the audience a slight glimpse of that?
Thanks, Ilona. I think one of the challenges we had when we were moving towards the high-level meeting in getting together civil society is that many of the civil society voices saw themselves as either in this disease or that disease. There was actually a big difficulty in trying to see people who saw themselves as civil society for health systems. In fact, I don't think there's anyone here who has to raise their hand who can say, civil society for health systems. Many people will be in HIV, TB, malaria, will be in sexual reproductive health. So that was a big challenge. People's movement, exactly. And when you get back to the country, that's the same challenge we find. That even when you try to put civil society together, the challenge of getting cross-cutting civil society voices is really difficult. And I think, even as I move forward to answer your question, I think that's one area we must invest in. And we must, needs to be built as a public good, to create health system, civil society, and support them, because most of the support right now is very vertical. In Africa, I have some very good champions here for universal health coverage and people engagement. I see the Minister of Health in Uganda here, Minister of Public Health from Guinea-Bissau, and I think as I was coming here, I saw the Minister of Health from Ghana. All these people who are actually very actively pushing in country. Because at the end of the day, listening to the conversations here by Margaret Chan and what Snow was saying, global consensus is critically important, but local action is more important. That if you have global consensus, but no local action, then you can have no movement for the people. The people do not actually feel the effect of the declarations. So when we look at the countries, we look at Rwanda, for example, making great progress. We look at Kenya now with a political declaration, political choice, but movement needs to happen. So we are that place where we need to jump. You look at Ethiopia, you look at Uganda now doing its national health bill, you look at South Africa. So there's a lot of movement going on. I think what I find missing is that local action requires active civil society because the promise must turn into action. And I think this is where we are not seeing a lot of movement because, again, the civil society is clustered into groups of verticalization. If we can now take this declaration and move down and say we want to engage society, not necessarily through activism, but working with government step by step to ensure that the promises government are making are actually put into action. Because as we say, governments report to their people. Everyone has a boss, and the boss of government is the voters. So if we can't have enough active from the voters, then we'll not have the activities happening. So for me, that's the next really big step. And then we can match it together with all the health system building blocks, including the most critical, which is financing, which we'll talk about later. Yeah.
Thank you very much. Somebody wanted to clap, I saw. Margaret, since we're discussing country-level things, could you say a word or two more about how this is developing in China? I mean, a tremendous challenge, as you've indicated, strong political will from the highest leadership. So how is China developing its UHC system now? What are the goals in 2030, China 2030? And what can perhaps be learned from that very strong political commitment?
Thank you, Ilona. As I was listening, Thank you, Ilona. As I was listening to Dr. Gigi, your 6 R's of the high-level meeting on UHC, the political declaration, I was counting how many China has met. That's very important. And you put the first one as political leadership. And I'd like to share with you some of the Chinese experience or lessons that we can learn. Political commitment, followed by financial input, and oversight to make sure things are being implemented. Oftentimes, there's a lot of talk, particularly at the global level, maybe even at the local level. Talks is cheap, right? Do we have the mechanism to hold policymakers, governments to account, to ensure transparency? So the measurement piece, the monitoring piece is extremely important. But all that would only happen if government, well, of course, you need to take advantage of the political system within the country and use it to best advantage. How can you move the needle? Get the attention of the political leaders. Political leaders are only interested in votes. So if you have an election cycle, as in the case of Australia, every 3 years, as in the case of US, every 4 years, as in the case of some other countries, every 5 years, and so on and so forth, find the right moment and work with the leader for them to appreciate the call from the people. Now, in China, there were 2 sayings. I don't know how to translate that into English. In 普通话, it says, 看病难,看病贵, meaning it is difficult to really see a doctor when I'm sick, and it is very expensive. to seek health care. That was the development at some point in China. And the call from the people caught the attention of the political leaders. So they begin to move forward. And in fact, the World Bank, many universities and WHO were among the group of people that have been advising the Chinese government to find its own mechanism. So to put it in a nutshell, I was counting on the 6 R's, and many of them were met. For example, political leadership, making sure no one is left behind, and that is a big deal for China. Poverty elimination, and making sure that no one is left behind, irrespective of which group of, well, there's 56 minority group in China. So, and of course, the quality of care. Now, we have quantity now. The quality we need to continue to improve. So all in all, what I'm saying is investment and then moving together. So that's why in this Boao Forum, Global Health Forum, I'm bringing in all the stakeholders, including the industry. I know that when I was Director General of WHO, some of my member states get very uptight when I talk to the industry. For example, IFPMA, why are you laughing? Why are you smiling? So you feel the pain, right? So when I was asked by Mr. Ban Ki-moon as well as the Boao Forum to take forward global health, the first question I asked is, does WHO FENSA apply to me? For those of you who know FENSA, I said, now I'm a free woman. I'm a retired person. I will do the right thing in the interest of the health of people. So I need to work with the industry. But one thing very clear, without conflict of interest. And we need to also honor the right balance of access to medicines, vaccines, at affordable costs. Industry, if they don't make money, what are they? They are not charity. Let's be frank. If you drive the price to so low that they are not making a profit, they will exit. And then you don't have the solutions that you need for keeping people in good health. So I've been working with industry in this platform. We are close, but we are very transparent and making sure there's no conflict of interest. Because Dennis, to echo what you said, global consensus requires global governance. Get all the stakeholders together to find solutions for people, because I do not hear the word people yet. We need to listen to the voices of people. Well, my famous saying, actually, the current Director General, he must be monitoring my speeches. And he said that, Margaret Chan always say, remember the people. And that's true. So where is the voices of the people? Now, civil society may think that they are representing the people. Some do not. So we need to be careful. So don't forget the WHO FENSA.
Thank you, Margaret. That leads to Dr. Nussa and maybe some response on that side, because there is concern in terms of what Margaret said, where the industry is perhaps not investing to the extent we would like to see it. Take the antimicrobial resistance agenda, for example. Some of the vaccine development is an example, and you might come back to that. So, how can we move that forward? How can it be a common agenda for UHC, where we're all trying to come together and produce those global public goods that were mentioned?
Thank you, Ilona. This is a very challenging and inspiring moment because I will try now to bring several thoughts I've heard together, and I could not possibly prepare for this. I have heard 1.5 years ago, I heard someone say in a breakfast meeting in Davos, there's only one public good, and that's money. And so I was just wondering now how to bring this aviation construct and do the final step on the parallel that you drew. We would need an industry for universal health coverage. And that's why creating business models for social matters is so absolutely important, although these are baby steps. The industry will not significantly invest into things which don't make sense to them. The question is, to what extent do we need to do more? Do we need to leave our comfort zone and be at least catalytic? For example, when it comes to antimicrobial resistance, how can the industry maybe be catalytic in blended financing instruments? And there are ways, and we will, during the next days, maybe hear a little bit more on this as well. And you spoke also about the narrative. Now, I'm a fan and a believer that language determines what people think and what people do. That's why language and the right narrative is so critically important, individually. What does that mean? What does it mean now in terms of the private sector and the language? The private sector uses words internally, for sure, as flagships, blockbusters. Doesn't really resonate with ministries of health. If I was a minister of health, it would certainly not resonate with me. I want to hear prevention. I want to hear how the private sector can work within the system, be asked to contribute, and not to lead always, but to contribute to elements of health system strengthening, and understand that ultimately those little elements will help increase a market, an absorptive capacity of a system which eventually poses something which is very meaningful for industry, a market. Margaret, I'm very happy that you've mentioned the role of monitoring and evaluation, because I can share a story of my own disruptive journey within a big multinational company. 4 years ago, when we started a non-communicable disease access program, we said we need to do something better than in the past. For sure, at least one thing. We need to embark on monitoring and evaluation independently. And as a matter of fact, Boston University only agreed when we also said, let's make not only the protocols, but the entire data set, even our contract with them, publicly available. You cannot believe what kind of disruption this has been internally. But I survived, I'm still here, and you can look into the data. And interestingly, the data is not just favorably for our company. We have not achieved everything we wanted to achieve. Now let's learn from it, and this is what is so critically important. Changing individually the narrative and the words we use, not to lead and own, but to contribute and to share. Not only announce something for PR reasons, but look at the outcomes. No one would start a clinical trial without mentioning the primary efficacy and safety endpoint. Yet some companies still go out and say, this is what we do. We donate 1 million now for an NGO, and we await a report. Does that matter? To me, it does not matter anymore. One person, and I conclude with this, one person once said to me, Harald, be aware of one thing. You cannot not lead. So it's not on only high-level declarations, it's on all of us in this room. It's on you, individually. What can you do? How can you contribute? How can you break down one perception that you may have had about the public sector, about multinational companies, about civil societies? It's about rethinking the language that we use and exploring things we can do together, all of us in this room. Thank you.
Thank you, Harald. Thank you. That's a nice lead into Frederick. I mean, you are Deputy CEO of a coalition. And if you could say a bit, how does that coalition function and what is your ultimate outcome? What is it that you want? And why is it that, this innovative research is so critical in trying to move our UHC agenda forward? And why does it need all those partners to be able to really do it?
Thank you. Yeah. Thank you for that segue, because I feel we are a partnership and we are a coalition that sort of sits between, public sector, both interests and partners, as well as the private sector. Because, back to Margaret Chan's point that the industry needs some incentives to actually function or to do its job. And CEPI was set up because of a market failure. There was a realization that when you have major outbreaks like the Ebola outbreak in West Africa in 2014, there were products that were sort of in the pipeline, but nobody had the incentive to actually take them forward. So that's the raison d'être for CEPI, trying to find that balancing point between securing access in the sense that, well, point one, you need actually to have products to discuss access. But then, of course, it's also critically important to use the public funds that we get in such a way that access is maximized, and that ultimately the products that we develop, which are vaccines for epidemic infectious diseases, are available for those that need them when they need them. And that is, of course, easily said, but the devil is in the details of actually how you implement that. And so we have moved from sort of a very detailed focus on how to do that to a more principle-based, where we have a number of mechanisms for actually making sure that the products that get developed are developed in such a fashion that the costs of making them is kept low, that any profit in top of that is controlled, that the prices are controlled at the end of the day, and that there are mechanisms to distribute these products between countries.
Thank you, and it shows, the need for partners who are willing to invest. It's very interesting, and that will lead me to Dr. Snow again, is that in Geneva, for example, partly through the support of the Swiss government, a group of investors has come together, investors for the Sustainable Development Goals. And for a whole week last week, they discussed, in what way do major investors need to change their approaches in order to help achieve the SDGs. Because frequently we only talk about companies, but we don't really talk about the whole investment world and where they choose to put their money and who they choose to move forward. And we've had first discussions, how one can bring those investors to the health table. I mean, the global health economy is due by people, are not quite in agreement when this will be, but some say, at the latest by 2021, the global health industry is going to be $10 trillion. That's a lot of money. That's a lot of investment, which doesn't always go where it should be going. And of course, the majority of that investment and that money is still in the developed part of the world. So if you put on your economist's hat, Dr. Snow, and think about, how would you structure, how would you motivate, incentivize this investment community to say, well, you might have looked at some of the other SDGs, invest, in healthy cities, or invest in climate change through, new kinds of approaches and innovations. How would you motivate them for health? Using your narrative, probably.
Exactly. Basically, freshwater economists will say there's only one way to motivate people, and that is through monetary incentives, and that bypasses the whole structure of thought within which we operate. the values, the social norms, and so forth. And therefore, providing a setting through a narrative that motivates them is, I think, our first task. Now, in looking for such a setting that will motivate investors, I believe once in a generation, perhaps, one reads a book that changes one's entire picture of how this health system is to be established in the world. And that happened to me relatively recently. That was a book by Detlef Ganten called The Health Formula, which is very simple. And like all important ideas, it's obvious in retrospect. That's great. So basically, the formula is that your health depends on your biology of your body. It depends on your environment, and it depends on your actions. So if you're going to do it in a formula, H, health, is some function of BEA, B-E-A, biology, environment, action. Now, that changes everything to my mind in terms of motivating investors, as well as motivating society. Let me just say a word before going on. We talk about human rights, and health is a human right. We should think of mutual obligations within a value system. And this formula helps provide the framework for exactly that. It gives us not a symptom symptom-related approach to health, but rather a cause-related. Let me give you an example. Diabetes, high blood pressure, arteriosclerosis, gout, arthritis, heartburn, gallstones, breast cancer, intestinal cancer, prostate cancer, often arise from overweight, as we find in this book. So, what is overweight caused by? Well, it's caused by sedentary work and recreation habits. That is due to the way we construct buildings and our social settings. So if we look at environment and action, what is the environment? Well, we want to change our environment. As you said, limit ads for unhealthy products, sit in appropriately designed chairs, etc. Actions, take brisk walks, do sport, reduce stress, lose weight, avoid sugary foods, and so forth. Now, if you think of the mutual obligations in which people are embedded in society, those are really things to take to heart. And then if you think about the role of government, naturally you think firstly of prevention in order to deal with this. And if you want to motivate investors, there's a whole slew of things that can be done to counter overweight that will then feed into all these different diseases. Now, there are countless other examples that can be given, but if we just keep in mind the simple formula that health depends on your bodily functions, your biology, your environment, and your action, and then to think about how to motivate an entire society to achieve health, then I think we're on the right track.
Thank you very much, Dr. Snow. We started late. We have 5 more minutes. I want to ask the other speakers to respond to that and to give me just 1 or 2 sentences on this motivation of society to generate health. Where do you think it would start, and where do you think the group, let me say it in general, that you come from, can most contribute to it? Harald. 2 sentences.
For each actor in society, there is different incentive mechanisms. We need to spell them out and try to cater to them.
Okay, different interests. Frederick?
Well, I think alignment of incentives is sort of the key word, and you know, from where CEPI sits, it's clearly we're a new push mechanism. There needs to be alignment of other mechanisms who will buy vaccines at the end of the day, just as an example. So I think alignment of incentives and having incentives for the right things would be my sort of...
Gitinji?
Well, I agree and disagree at the same time. I think mutual obligation is really critical, but at the same time must be enabled by governments removing barriers to just mutual obligation. Because when you tell people to have the mutual obligation, but they can't access clean water, they can't access toilets, they have poor security, then you have a challenge. So it must be put in that construct, that the government has the responsibility to remove the barriers so they can then meet their obligation. That's the first thing I have to say. The next thing I have to say is that, and I hope these are the final comments, are they? Because there's something I wanted to add there, that domestic resources in their own are not enough, because in many LMICs, even if you did collect taxes, you didn't steal them, like sometimes they're stolen, and you allocate them to health, you still end up with $50 per capita. Primary health care requires a minimum of $80 to $100 per capita. Multilateralism is critical for achievement of UHC. Finally, to Margaret's point, people are not recipients of healthcare. Health is made by the people. They are co-creators, and therefore they must be central to every health system that we build. People must be at the center. Thank you.
Thank you, Margaret.
Well, Ilona, I think, the phrase, maybe you were one of those who initiated that. Health is political. At global level, we talk about the importance of global consensus and global governance by global agreement. At the local level, it involves the government and all the stakeholders. Everyone has a role to play. I mean, in China, we used to say, 管好你的嘴巴. 就是呢, in order to make sure you don't have diabetes, you don't have heart disease, and so on and so forth, make sure you eat properly. And then healthy lifestyle. But it's easier said than done. So in a nutshell, health is political, both at the global level and at the local level. It requires all stakeholders to find a consensus to move forward.
Thank you. And Carissa?
I think you need to empower people. You need to empower the ordinary man on the street, that he can demand from his government, that he or she can also take responsibility for their own health, and that they can push partners towards a global social movement. I think putting people at the center is very important. Give me 1 minute. I think we are at a moment that we must be extremely careful in the whole UHC movement. We have to make sure that for the last time that it works. And for that, you will need passion that endures. Last night, somebody talked about passion. Passion that endures, because there will be hard times. And the way that your passion drives you and continues to make you both an advocate and an actor for people's health is going to be important. So thank you.
Thank you, Carissa. And that takes me to Adrian Rich, who said, "A wild patience has taken me so far." I think that's what we often need in global health. Please say thank you to this fantastic panel. And thank you very much for coming. And you heard from Carissa and others, you are the movement. Take action. Thank you.